40% of women suffer from some form of sexual dysfunction. But, the medical silence around it is just so deafening that this $2,500 injection of your own blood has become this wildly popular treatment.
Yeah, it really highlights a massive diagnostic gap.
No.
Female sexual dysfunction, which is everything from painful sex to a total lack of desire. It's incredibly complex.
Right.
And historically, the medical establishment has, well, either dismissed these symptoms entirely or just offered very little in the way of targeted solutions.
Which basically creates a vacuum. And into that vacuum steps the O shot, right? Or the orgasm shot, as it's called.
Exactly. It's aggressively marketed online.
So we have to ask the central question for this deep dive. Can the O shot actually improve arousal? I mean, is this a genuine biological breakthrough, or is it like a costly illusion preying on patients who have just been ignored by traditional medicine?
To get to the bottom of that, we're looking at a pretty thick stack of sources that represent both sides of very heated medical debate.
And we should tell you what those are. We've got official clinical practice guidelines, right?
Yeah, from the British Menopause Society and the UK's National Institute for Health and Care Excellence, or NICE, as they're called. We're also pulling from systematic reviews of regenerative gynecology, specific clinical trial data out of Egypt, and on the other end of the spectrum, a highly critical analysis from Dr. Jen Gunter.
Right, published in the Vagenda. So our mission for this deep dive is to really cut right through all the glossy marketing noise.
Definitely.
We're going to look impartially at the biological data, the fierce controversy, and the underlying mechanisms to help you understand the real science of female sexual arousal and how it's actually treated.
That's the goal.
Okay, let's unpack this. Before we debate the efficacy of this thing, we really need to understand the physical procedure. So the core of the O shot relies on PRP, right? Platelet-rich plasma.
Right. PRP is kind of a cornerstone of regenerative medicine. So a clinician draws blood from your arm and spins it in a centrifuge.
Okay, just like a standard blood draw.
Exactly. And that high-speed rotation isolates the platelets from the red blood cells. Platelets are heavily involved in the body's natural healing cascade.
They're the things that stop you from bleeding when you get a cut, basically.
Yeah, exactly. They're essentially these biological reservoirs packed with growth factors, like vascular endothelial growth factor, or VEGF, and epidermal growth factor.
Okay, so to use an analogy, if you scrape your knee, your platelets are kind of like the body's elite repair crew.
That's a great way to put it.
They rush to the site to stop the bleeding and, rebuild the tissue. With PRP, they're taking that exact same repair crew, concentrating them, and dropping them directly into the pelvic region.
Right, specifically injecting them into the clitoris and the anterior vaginal wall, near the G-spot area.
To renovate the local tissue.
That is the biological theory, yeah. The injection of these highly concentrated platelets releases those growth factors alongside cytokines.
Cytokines, those are the immune system messengers?
Yeah. Exactly. They're the chemical messengers of your immune system. So when injected, they signal the local tissue to mount a controlled, localized inflammatory response.
Oh, interesting.
And the desired outcome here is angiogenesis.
Which means the creation of brand new blood vessels. And, if we think about the mechanics of arousal, that actually makes perfect sense.
It does.
Because female arousal relies fundamentally on blood flow. The clitoris is this extensive vascular network that requires, rapid, massive engorgement to become sensitive and facilitate orgasm.
Right. So the theory is more blood vessels equal a better biological infrastructure for arousal.
But I have to push back here.
Sure.
If the body already knows how to heal itself, why do we need to manually move these platelets around with the syringe? Doesn't the human body naturally send blood and platelets to areas that need regeneration?
Well, the counter-argument from regenerative medicine is that the body is inherently efficient, right? Sometimes to a fault.
How so?
As tissues age or lose estrogen, they don't necessarily signal an acute injury. So the body doesn't bother dispatching that elite repair crew you mentioned.
Oh, I see. Because there's no actual cut or wound.
Exactly. By manually injecting a hyper-concentrated dose of platelets, you are artificially tricking the tissue into a massive healing cascade.
You're forcing resources into an area that might otherwise be, chronically starved of regenerative signals.
Precisely. And this ties into how clinics actually assess the symptoms women walk in with. Dyspareunia, which is the medical term for painful sex, isn't just one monolithic thing.
Right. Our sources highlight that pain is heavily mapped out during an initial assessment. Like, there's superficial pain, right?
Yeah, superficial pain, which patients often describe as a burning, tearing, or like a paper cut feeling right at the entrance of the vagina.
Okay, and then there's the deep pain.
Right. Deep pain is more of a bruised, sort of visceral collision feeling much higher up inside the pelvis.
And distinguishing between those two is a critical triage step, isn't it?
It's vital. Deep pain often indicates structural or systemic issues within the pelvic cavity, like endometriosis, adenomyosis, or pelvic inflammatory disease.
And the O shot is definitely not targeting that.
No, not at all. It is specifically marketed for superficial pain, generalized sensation loss, and conditions like lichen sclerosis.
Lichen sclerosis, that's where the skin of the vulva becomes thin and really fragile, right?
Yes, exactly. Thin, fused, and incredibly fragile. The O-shot is aimed at the superficial tissue architecture.
Okay, so since the biological theory of forced tissue renovation sounds, fairly plausible, what actually happens when you test it? Let's look at the pro data.
Right.
We have a retrospective study from Abdel Salam and colleagues in Egypt involving 30 postmenopausal women suffering from severe female sexual dysfunction. And the numbers they reported are staggering.
They really are. They utilize the Female Sexual Function Index, or FSFI. That's a validated diagnostic questionnaire scoring domains like desire, arousal, lubrication, orgasm, satisfaction, and pain.
And what happened after the PRP treatment?
Post-treatment, the women's total FSFI scores jumped by 72%.
72%.
Yeah, the baseline average was 16.5, and it rose to 28.5.
Oh, wow. Looking at the breakdown, the specific improvements answer our central question about arousal perfectly. Like, the arousal scores literally doubled, going from 2.1 to 4.1.
And lubrication jumped from 3.0 to 4.8.
Orgasm scores went from 1.5 to 4.0. I mean, beyond just function, a secondary scale measuring sexual distress showed that the psychological burden of their dysfunction basically plummeted.
It is very compelling data, and it is echoed in broader analyses too.
Like the Ismail review.
Exactly. The systematic review by Ismail and colleagues looked at 17 different studies on PRP for vaginal rejuvenation.
17 studies.
Yeah, and across the board, they noted a 20 to 60% increase in vaginal lubrication and a 25 to 70% improvement in orgasmic function.
And the side effects?
Remarkably minimal. We are talking about transient swelling, localized bruising, or, a temporary burning sensation at the injection site.
That sounds incredible. There is also an interesting protocol note here. Clinics performing this use a traffic light system during the pelvic exam.
Right. That's a really important aspect of the care.
The patient is given total vocal control. Green means go, amber means slow down, and red means stop immediately. And post-procedure, they are advised to take 24 to 72 hours of pelvic rest, with a strict ban on NSAID painkillers like ibuprofen.
That NSAID is biologically vital to the procedure's premise.
Why is that? Because they're anti-inflammatories.
Exactly. The entire mechanism of PRP relies on initiating an inflammatory cytokine cascade to rebuild the tissue. If a patient takes an over-the-counter anti-inflammatory, they are biochemically neutralizing the exact growth factors they just paid thousands of dollars to inject.
Wow, okay. But I want to pause on that traffic light system for a second because I think there's a massive psychological component hiding in plain sight here.
Oh, absolutely.
Think about it. A woman goes into a clinic with profound sexual distress, something doctors may have dismissed for years. This new clinic sits her down, gives her total bodily autonomy with a green, amber, red traffic light system, and validates her pain.
Right. It's a completely different environment.
Giving a patient that level of control and validation during an intimate exam might actually be profoundly therapeutic in itself, right? Completely independent of whatever platelets are in the syringe.
That observation strikes at the very heart of sexual medicine. The psychological component of arousal is so dominant that the context of care, just being listened to, being given control, participating in a novel, high-tech ritual, it can dramatically alter a patient's physical response.
Which brings up my skepticism. We are looking at a 72% improvement in sexual function with minimal side effects. If these numbers are an objective biological reality, why isn't this the absolute standard of care for every single woman experiencing menopause or arousal issues?
Well, those glowing numbers from small trials are exactly what make the broader medical community so nervous.
Yeah.
When evidence is highly fragmented, it leaves the door wide open for critics. And the most prominent voice pushing back against this is Dr. Jen Gunter.
Yes, Dr. Gunter is a very well-known gynecologist, and she published a scathing critique of the O-shot on her platform, The Vagenda. And to be clear to everyone listening, we aren't taking sides here. We're just outlining the fierce controversy as it exists in our sources.
We're just looking at what's being said.
So she calls the procedure, which generally costs between $1,500 and $2,500 out of pocket, an untested scam.
Her critique is rooted in a fundamental biological counter-argument. We established earlier that PRP functions as a wound-healing mechanism.
Right.
Gunter argues that in the vast majority of female sexual dysfunction cases, there is no wounded, diseased, or traumatized tissue to heal. The issue is often functional, neurobiological, or hormonal.
Right. She points out that when actual surgeries are performed around the clitoris or the vagina, procedures that inherently cause trauma and trigger a massive natural release of the body's own growth factors to heal the surgical site, we do not suddenly see those patients reporting mysterious, dramatic improvements in their orgasms post-surgery.
It's a very logical counterpoint. If a massive natural cytokine release from surgery doesn't cure orgasmic dysfunction, why would a localized PRP injection?
Exactly. It completely challenges the core mechanical premise. But Gunter's critique extends far beyond the biology, right? She targets the origins of the procedure itself.
She does. The O-shot was invented and trademarked by Dr. Charles Runels. The sources note that Dr. Runels is an internal medicine physician, not a board-certified gynecologist.
Oh.
And he reportedly began his experimentation with PRP by injecting his own penis and subsequently injecting his sexual partner.
Wait, really? He tested an experimental blood spinning procedure on his own penis and then injected his intimate partner.
According to the sources, yes.
I mean, setting aside the massive ethical red flags of treating an intimate partner with experimental medicine, the timeline gets even stranger. The FDA actually disqualified Dr. Runels as a clinical investigator back in 2009.
Yes. And the foundation of his research is equally scrutinized. To legitimize the O-shot, he published an 11-patient case series.
Only 11 patients.
Just 11. However, it was published in OMAIN-CS, an organization widely classified as a predatory publisher.
For an audience familiar with medical literature, the implication of a predatory journal is huge. They completely bypass the rigorous peer review process that prevents junk science from entering the medical consensus, right? As long as the author pays the publication fee.
Exactly.
So you have an FDA-disqualified doctor paying to publish an 11-person study.
And the lack of peer review is pretty apparent in the text itself. Runels listed his institutional affiliation simply as medical school in Alabama.
Just medical school.
Just medical school. Furthermore, the published paper misspelled the word dyspareunia, which is the core medical condition, painful sex, that the paper was allegedly investigating.
Oh, wow. So it's not exactly a rigorous clinical trial. Gunter also takes direct aim at the business model, doesn't she?
Yes, because the term O-shot is trademarked. Doctors pay $997 to receive training from Runels, and then they have to pay a $97 per month licensing fee just to legally use the name in their marketing materials.
So it's essentially the franchise model applied to gynecology.
That's a good way to describe it. This specific financial structure radically alters the online information landscape.
Because you aren't just paying for a scientific procedure, you're paying for the branding. And since every franchisee needs to recoup their investment, there is a massive financial incentive to flood the internet with highly optimized, glowing reviews.
Exactly. It makes it nearly impossible for a patient to just Google the O-shot and find objective, critical information over all that marketing noise.
The clinical optimism basically becomes an echo chamber.
It does. But as analysts, we still have to look impartially at the data that does exist, even the pro data. If you revisit that systematic review by Ismail, the one showing the 20 to 30, it's severely fragmented.
Because there's no standardization. Right.
None whatsoever. There is massive heterogeneity across clinics. Some draw a large amount of blood and inject 10 milliliters of PRP. Others inject barely 2 milliliters.
Wow, that's a huge difference.
Yeah, the centrifuge speeds vary. The preparation protocols vary. But the most glaring issue in sexual medicine research is that the vast majority of these O-shot studies are small, they lack long-term follow-up, and crucially, they are unblinded.
And in the realm of sexual medicine, the lack of blinding is basically a fatal flaw. When a patient pays $2,000 for a highly invasive novel procedure, they want it to work.
Absolutely. The psychological expectation of arousal, coupled with a clinician finally paying attention to their pelvic floor, creates a placebo effect that can literally alter blood flow and sensation.
Yeah. That is the crux of the scientific hesitation. So where does this leave the patient? With staggering success stories on one side and accusations of a trademark scam built on predatory journals on the other, official regulatory bodies have had to step in and draw a hard line.
They have. Looking at the official stance from NACE in the UK and the British Menopause Society, their guidance is unequivocal.
Which is?
Regenerative injectables like PRP, alongside energy devices like vaginal lasers, are absolutely not considered first-line treatments for sexual dysfunction. They are officially classified as experimental or investigational.
NICE specifically dictates that the current evidence regarding long-term safety and clinical efficacy is inadequate, don't they?
Yes. Their directive is that procedures like the O-shot should only be offered under strict clinical governance and audit.
Meaning in practical terms, it should be part of a rigorously tracked, structured research trial, not a lucrative out-of-pocket add-on menu item at a local med spa. So what does this all mean for someone currently struggling with arousal or pain? I mean, jumping straight to a $2,500 O-shot without trying the medical basics first is like tearing down the walls of your house to fix a draft before you've even checked to see if the window is open.
That's a really good analogy. You have to start with the proven, foundational fixes. And the guidelines insist patients start with evidence-based gold standard pathways.
And what are those gold standards? Let's start with genitourinary syndrome of menopause.
Right, which covers vaginal dryness, superficial pain, and tissue thinning. The absolute foundation there is localized vaginal estrogen.
And this is distinct from a systemic pill that circulates through your whole body, right?
Very distinct. It is a targeted cream, a pessary, or a ring that delivers estrogen directly to the vaginal tissue. It restores the cellular thickness, elasticity, and natural lubrication.
And it's safe.
It is heavily researched, incredibly safe, and highly effective for superficial architectural pain.
Okay, but what if the symptoms are systemic? Say, severe hot flashes combined with a total loss of libido.
Then systemic hormone replacement therapy is considered. But our sources also highlight a fascinating, frequently overlooked treatment for hypoactive sexual desire disorder, or HSDD.
Oh, right. And that is off-label testosterone therapy. I wanted to ask about that. Testosterone for women.
Yes, testosterone is reflexively categorized as a male hormone, but it is biologically vital for female central nervous system arousal pathways.
Okay, so how does it work?
The British Menopause Society guidelines note that when localized or systemic estrogen therapy alone hasn't resolved a severe lack of desire, a specialist might prescribe off-label testosterone. It's usually a 1% gel applied in microscopic doses.
Just to keep the circulating levels strictly within the normal female physiological range.
Exactly. And when monitored correctly, it is proven to significantly improve sexual desire, arousal, and orgasm frequency in postmenopausal women.
But the body is a complex machine, and the issue isn't always hormonal. If a patient describes that deep pain we talked about earlier, that feeling of physically hitting a wall inside the pelvis, the issue might be muscular.
And that is where pelvic floor physiotherapy comes into play. A hypertonic pelvic floor means the muscles supporting the pelvis are in a state of chronic rigid spasm.
So they basically can't relax to accommodate penetration.
Right, which causes severe pain and entirely short-circuits the arousal process. A specialized physiotherapist can work with the patient to downtrain and consciously relax those specific muscle groups, resolving the mechanical barrier to intimacy.
And for patients who cannot use hormonal treatments, perhaps due to an oncology history or simply prefer not to, there are robust, proven alternatives too.
Yes, like vaginal DHEA, also known as progesterone.
Right, which is a daily insert that chemically converts to active hormones locally inside the tissue, improving cellular thickness without significantly altering systemic blood hormone levels.
Exactly. And we also shouldn't underestimate the foundational power of high-quality, non-hormonal moisturizers.
Specifically those utilizing hyaluronic acid.
Right, which actively bind water to the tissue to maintain hydration and comfort over time. The medical toolkit for female sexual dysfunction is actually quite extensive and well-researched when you move past the cosmetic marketing.
So to distill this deep dive for you and answer our core question, can the O-shot improve arousal? The O-shot takes a very promising concept from regenerative medicine using your blood's own platelet growth factors and applies it to the profoundly complex issue of female sexual dysfunction.
And yes, small studies do show exciting, sometimes dramatic improvements in arousal, lubrication, and orgasm.
But those improvements must be weighed against a stark reality. The utter lack of procedural standardization, the prohibitive out-of-pocket costs, the highly questionable FDA-disqualified origins of the trademark's inventor, and the lack of robust, blinded biological proof mean the O-shot remains a highly experimental investigational option at best.
That's the scientific reality right now.
Your sexual health, your comfort, and your physical pleasure absolutely matter. If you are experiencing pain or a sudden, distressing drop in arousal or desire, you should not feel dismissed by the medical system.
No, absolutely not.
But you also shouldn't feel cornered into an expensive, poorly regulated cosmetic fix without first thoroughly exploring the proven gold standard therapies. Talk to a trusted, specialized doctor about localized estrogen, pelvic physiotherapy, or testosterone therapy first. Explore the foundational science before you pay for the experimental branding.
I think it leaves us with a fascinating paradox to consider, too.
Oh,
Well,
oop.
given how deeply intertwined the physical and psychological pathways of sexual arousal are, and the notoriously high rates of medical dismissal women face regarding pelvic pain, if a woman pays for an O-shot and experiences a miraculous return of her arousal, we really have to ask what actually healed her.
Right. Was it the unproven angiogenesis from the platelets?
Or was it the powerful physiological relief of a clinician finally giving her control of the exam room, validating her distress, and actively trying to treat a problem she was told she just had to live with?
It makes you wonder, maybe the real miracle isn't the growth factors in the syringe at all. Maybe the most potent medicine is just finally being seen in a diagnostic landscape that has been murky for far too long. Thanks for joining us on this deep dive.